Thank you, John. So now we're going to hear from Dr. Kurtzberg, who's going to talk about real-world specifications for release of cord blood and cord tissue.
Hi, and thank you. And I'm going to take us back a little bit to the clinic, and I think it's a good segue into Peter's talk, where he's also going to talk about using real-world evidence for product registration. I don't know if you know, but there are more than 6 million cord blood units banked around the world by families contracting with private or public bank, private or family banks. And these banks have varying degrees of accreditation or licensure depending on their country's regulation. In the public banking system, where cord bloods are banked and released for a hematopoietic cell transplantation, cord blood unit description and qualification is dependent upon post-processing specifications for which there's general agreement worldwide, although there are not, all of these banks do not use the exact same manufacturing techniques. They've agreed on specifications for the final product that they all have to achieve. In the United States, although licensure is encouraged for public banks, it's not required, and non-licensed banks or units can be distributed for hematopoietic cell transplantation under IND. And there's actually no guidance yet regarding licensure of private cord blood units from private banks from the US FDA. The current indication for use of unrelated donor publicly banked cord blood units is for hematopoietic reconstitution after myeloablative therapy. But if you think about a cord blood unit, less than 1% of the cells in the unit are hematopoietic stem cells, and that's really being very generous. It's much lower than that. Cord blood's a heterogeneous product with several types of cells, and many of these non-hematopoietic stem cells have potential for therapeutic uses. I think you've seen at this conference over the last 2.5 days. So how can we utilize cord blood units in the clinic for indications other than hematopoietic cell transplantation? Cord blood is undergoing testing right now under IND as an infusional therapy for pediatric patients with HIE, CP, autism, and adult patients with stroke in my program. And you heard over the course of this conference of programs manufacturing NK cells, CAR-NK. There are people manufacturing CTLs, CAR-T. There are people using the red cells from cord blood for allogeneic transfusion. So there are a lot of other very valuable cells in a cord blood unit. So I'm going to use our work to illustrate some points. We conducted phase 1 trials and then a randomized placebo-controlled trial, which we published in Stem Cell Translational Medicine, about the effect of autologous cord blood infusion on motor function and brain connectivity in young children with cerebral palsy. And this trial was based on preclinical evidence that we had in hypoxic models, which I'll show you in a minute and which have been presented at this conference. But the ideas really came from observations we made in children with metabolic diseases undergoing HSCT, and we just learned things about what cells in cord blood could do for the brain. So very quickly, this is work of Arjun Saha in our lab, but we showed that cord blood mononuclear cells and cord blood CD14 cells in particular could rescue brain tissue from oxygen glucose deprivation, which here are normal cells. Here is what happens after OGD, where you get, in pink, a big astrocytosis, and in green, you lose the neurons. And if you co-culture the tissue that has been shocked with cord blood mononuclear cells or cord blood CD14 cells, you rescue the tissue. This is due to different gene expression, and we showed that this is a property of cord blood CD14 cells and not adult CD14 cells. And we are continuing to study why that might be, but it probably has to do with the lineage of the 14 cells in cord blood, which is not all from the bone marrow and maybe from yolk sac. Oops. We also showed in a baby rabbit model that was validated to study interventions in cerebral palsy that infusion of human cord blood cells on day 1 of life after in utero asphyxiation rescued the rabbits from the motor deficits they would typically develop in this model, which could be assessed on days 7 and 14, which is somewhat equivalent to 1 and 2 years of life in humans. So back to the paper, we tested 63 patients who had qualified autologous cord blood units banked, and it turned out they came from 16 banks around the world, who were ages 1 to 6 years, had CP with spasticity, or a GMFCS level of 1 to 4, which is a level that rates severity in children with CP, and which has been well validated to document natural history of development of motor function without intervention in these children. We had a placebo, which was TC199, a pink tissue culture media with 1% DMSO, which was the amount we know is in our washed cord blood unit after thawing. So I've said this before, but everybody got pink liquid that made their breath smell so that we could blind the order of infusion. It was a randomized, placebo-controlled crossover study, so each child got cord blood and placebo at an interval of 12 months, but the order of infusion was blinded. And the primary endpoint was change in GMFM score at 1 year post-infusion. The GMFM scale, again, I don't have time to go into it, but it's well validated for kids with CP. And I just want you to see that you can't use raw numbers, because a child who is relatively mild, level 2, at a young age will gain a lot of points, even though they have CP. A child who is a little bit more severe and at a year or so older will not gain very many points at all. And this measure is administered by a trained physical therapist who watches the child do 66 different motor functions, and the child only gets credit if they do it in front of the therapist. So you've all had many of you have had 2-year-olds, and if you say jump and you know they can but they won't, they don't get credit. So it's really observed by an independent person. We decided that we would call a response essentially an increase in function that was 30% above what would have been predicted for the change of that child 1 year from the study entry. And I showed this many times and earlier, and I'm just summarizing, but we did show that children getting a cell dose of 25 million cells per kilo or higher in blue had a statistically significant increase in motor function above what would have been predicted by their age and level of function at study entry. And in 38 of those children with the analyzable images, we were able to show on whole brain connectivity that the motor tracks, this is shown looking front, side, and top down, did increase, and that was associated with the increase in function. So if you see a red line or a turquoise dot, the p-value is less than 0.0001. Now this is a small number of patients, but and there are probably 10,000 children a year diagnosed with cerebral palsy, but they don't all have autologous cord blood stored, and they also all don't have a qualified autologous cord blood stored. So it took us 4 years to accrue the 63 patients. And just because I think a picture is worth 1,000 words, here's a child who was a responder. So at study entry, he cannot walk independently. He has braces. He crosses his leg because he's spastic, and that's called scissoring. So he can only walk with the walker. And a year later, he can walk independently. He can even go over the bar. He's not scissoring anymore. He's not spastic. This is more than the predicted response that would be part of the natural history of a child with that degree of CP. And I think, if you really think about it, taking a kid from the first picture to the second picture changes his whole life. It changes his family's whole life. If he were to stay like this, he would, never be physically independent. But at this point, he can build on the change he made, and he's going to have a much more normal, more functional adult life. So, our logistics in this study were, which was done under IND, to have a database for patient registration, an online consent to have obtain medical records, videos, and blood tests on the children. LabCorp cooperated with us so the child could go to their local lab to get testing. Eligibility determination was based on this information. cord blood unit was qualified, and I'll talk about that in a minute. If it was everything passed, we shipped the cord blood to Duke before the patient's appointment for his or her infusion was scheduled. Then the infusions were scheduled, the children came, they got assessed, infusions were performed in our day hospital, they got IV pre-meds, IV infusion, and follow-up with IV fluids. They also had MRI and assessment for their motor function and other activities and cognitive function by specialists in our team. And then just to say, as part of this, we developed SOPs for cord blood receipt, thaw, wash, formulation for administration, for patient infusion, and then CRFs for capturing all the data from the study, which included the eligibility data, the graft characterization, the infusion information, response, and safety data. So the cord blood units were autologous. They happened to turn out to be banked at 16 family banks around the world. The bank report was reviewed, provided to us by first the parents and then the bank. Identity was confirmed by obtaining HLA on the patient and HLA on an attached segment or a sample from the cord blood unit, and they had to match. And then potency was determined at Duke with an assay we developed, which gives percent viability of CD45, percent of LDH bright cells, CFU growth, and percent viability of 34, which was for information only. And we developed this chart of specifications, which is in our paper, which also included at the pre-information from the bank that there had to be a certain cell count, and in this study it was more than 10 million cells per kilo. Viability had to be tested and more than 80% on the fresh product. Sterility culture had to have been done and negative. Maternal infectious disease testing had to be done and negative, except for CMV. And again, a test sample had to be available for confirmatory HLA. So we did the study, we had that data. It's a small study, but it's a rare disease, and we actually got orphan designation in a formal process from the FDA. We went to the FDA, presented a briefing package to have an end of phase 2 meeting. We asked if we could consider this homologous use because of our data showing that the monocytes were an active cell and they were acting in the child as they would have in the cord blood. We developed ways to qualify manufacturing from the multiple family banks. We asked if we could be the BLA or the responsible party by having a terminal manufacturing process for administration related to a treatment indication. So I'm making something up, but it's sort of like having a treatment BLA. So we got back answers that were not what we hoped for. So it was kind of a very disappointing day. But FDA said no, that this isn't homologous use and that we could consider an application for a combination product and develop a potency assay for the monocytes. We asked about qualifying manufacturers from multiple family banks, and they said no, the BLA holders should ensure common manufacturing at all banks, which is not possible in the private world. We asked about terminal manufacturing, and they said no, that again, the whole manufacturing had to be standardized unless we could have oversight over all these banks. And we asked about a treatment indication BLA, and again, it was the same message. Manufacturing had to be standardized, and the BLA holder, which in this case would have been us, would have to be responsible for all of that. So I know there's a lot to work on, and we are committed to doing it, but what would I like to see? I made some assumptions. One, family banks are not going to get BLAs. Even if US family banks got BLAs, there's no guidance for that now, and many of these banks are outside of the US. I also know these therapies have to be safe, and they are, and we have to prove efficacy, but they meet a big unmet need. I think we need agreement that this really is homologous use, which might lead to the idea that this is a 361 product and doesn't need further regulation, or if it does require a BLA, that qualification by the user or the treating center, who would be the BLA holder of the initial manufacturing, should be okay. I really think in the public system, we've done that. One bank uses a CPAX, and another bank uses an AXP, and another bank uses a manual method, and another bank uses Prepacite, but they all come to the same final specifications of that unit, and I don't see why we can't do that in the private area as well. I think the BLA could just focus on the manufacturing, if you will, that's related to the thaw, wash, and dilution for administration at the treatment center, and it would be a treatment BLA, so to speak, instead of a primary manufacturing BLA. As a segue into Peter's talk, I'm changing subject now a little bit. We also opened an expanded access protocol because we had safety data for children with brain injury related to HIE or children with autism or children with CP. And there were so many families wanting to come have infusions of their children's products, and our clinical trials, which are still ongoing, had limited spaces and limited eligibility, so there was no way all of those children were going to have access to care with our clinical trials. I will also just say, I have an inbox, I keep these emails in. My team has thousands because we have a way to contact us in a database, but I personally have 20,000 plus emails in this file that I've gotten over the last couple of years. And I answer them, but there are a lot of people very unhappy with this. So the eligibility for this expanded access protocol, which was to provide access and collect additional safety data, includes children ages 0 to 18, so pediatric patients, with the diagnoses listed here. They get an infusion and have safety follow-up for the 12 months post-infusion. And we've treated 320 patients to date. Colleen presented the data on that, and I won't review it. But again, we could have treated 3,000 or maybe even more. We just don't have the infusion beds to do that. We're hoping a few other centers partner with us under our IND to continue to provide access while we finish the appropriate clinical trials to really see if we can or cannot prove efficacy. So how do we use real-world data to assess efficacy and safety in this expanded access protocol? I've thought a lot about it, and my take-home message is it's really easy to assess safety. You can do questionnaires, you have your infusion where you observe the patient, you can follow them up the next day for immediate infusional toxicity, you can contact the families to get later safety data. But efficacy data, we're not assessing on our current EAP because it's really hard. Why not? First of all, if we sent children who are coming to us from all over the world back to their physical therapist or back to their autism doctor for testing, it would cost that family money. And the people doing the testing may not be certified to do that particular test the way you would require on a clinical trial. So for the GMFM, if a PT does it on our clinical trial, they go through a accreditation certification process. But PTs in the community know how to use the test, and they may not go through the certification. And if they don't, and they have to pay for it, so they're not always incentivized to do it. We also, just the feasibility of assessing efficacy is hard. You need a database to collect the data. But we have thought about what could we do. We could standardize the GMFM testing and require follow-up, but again, it would cost the physical therapist and the parents. For autism, parent-reported measures, as I showed you the other day, have a high placebo background, so I don't think they're ideal for proving efficacy or not. And physiologic measures like eye tracking are being developed to be used on an iPhone or through FaceTime, and maybe that'll be a way we can have an objective follow-up for children with autism. So I just really wanted you to think about all these things. I think the pathways for regulation of autologous-related cord blood that is unmanipulated during manufacturing are not clear. I think homologous use definitions should be expanded to allow heterogeneous products to have multiple indications without being combination products in the sense of what I would think of, which is cells plus a device or something like that. Millions of parents have invested in this resource and should have access to safe and effective therapies if they exist. And parent-reported outcomes for efficacy of cell therapy products will be difficult to create, validate, and implement, but if we could do it, they could add useful data to support clinical trial or clinical indications for approvals of novel cell therapies. So thank you, and thank you again to my team that enables me to stand up here and tell you about our work.